Hello everyone, my name is Pawan Pawar. My topic for presentation is beta-lactam antibiotics, in which I am going to cover the semisynthetic penicillins. Moving towards the introductory part, firstly we will see how semisynthetic penicillins are produced. They are produced by chemically combining specific side chains in place of benzyl side chain of penicillin G or by incorporating specific precursors in the mold cultures. Now what is the need of producing semisynthetic penicillins? They are produced to overcome the shortcomings of penicillin G, which is the poor oral efficacy because they are destroyed by the gastric acid. The second one is the susceptibility to penicillinase enzyme. Penicillinase is an enzyme produced by certain bacteria which destroys the beta-lactam ring in the structure of the penicillin G and leads to its functional disability. The third one is its narrow spectrum of activity, and the fourth one is the hypersensitivity reactions caused by it. Now firstly we will see the classification of semisynthetic penicillins. In the classification of semisynthetic penicillins we have three categories. The first category is acid resistant alternative to penicillin G. In this category we have the drug phenoxymethyl penicillin or the penicillin V. In our second category, that is penicillinase resistant penicillins, we have three drugs which are methicillin, cloxacillin and dicloxacillin. In the third category, that is extended spectrum penicillins, we have further three more categories which are aminopenicillins, carboxypenicillins and uridopenicillins. In aminopenicillins we have ampicillin, bacampicillin and amoxicillin. In carboxypenicillin we have carbenicillin and the ticarcillin. In uridopenicillins we have piperacillin and the meslocillin. Now we will see each category one by one. So our first category is acid resistant alternative to penicillin G. As the name suggests, the drugs of these categories are acid resistant. The drug we have is phenoxymethyl penicillin or the penicillin V. It is an acid stable drug. It is used to treat streptococcal pharyngitis, sinusitis, otitis media, less serious pneumococcal infections, trench mouth and in the prophylaxis of rheumatic fever where the oral drug is required. Its pharmacokinetic is, its oral absorption is better, peak blood level is reached in 1 hour and plasma half-life is 30 to 60 minutes. Its dose is 250 to 500 mg in adults. In infants, 60 mg of dose is given, and in children 125 to 250 mg of dose is given in the intervals of 6 hours. Our second category is penicillinase resistant penicillins. These congeners have side chain that protect the beta-lactam ring from the attack by the staphylococcal penicillinase enzyme. As I already said, penicillinase is an enzyme which destroys the beta-lactam ring in the structure of the penicillin G and leads to their functional disability. The drugs from this category have indication towards the infections caused by penicillinase producing staphylococci. However, these drugs are much less sensitive towards the non-penicillinase producing bacteria. The first drug we have is methicillin. It is highly penicillin resistant, but it is not acid resistant. That is, it is destroyed by the gastric acid. However, methicillinase resistant Staphylococcus aureus have emerged in many areas. Its adverse effects are hematuria, albuminuria and the reversible interstitial nephritis. The second drug we have is cloxacillin or the dicloxacillin. It has an isoxazolyl side chain in their structure and they are highly penicillinase as well as acid resistant. They are more active than methicillin, but they are not used against the methicillinase resistant Staphylococcus aureus. Also, these are less active than the penicillin G. Hence, they are not used as a substitute for the penicillin G. Its pharmacokinetic is, it is absorbed from the oral route. It is more than 90% plasma protein bound and elimination occurs primarily by kidney, also partly by the liver. Its plasma half-life is about 1 hour. Its dose is 0.25 to 0.5 gram given orally in the intervals of 6 hours. For severe infections, 0.25 to 1 gram may be injected either intramuscularly or intravenously. Now the third category we have is extended spectrum penicillins. In this, the first category is aminopenicillins. As the name suggests, this group has an amino substitution in their side chain. The drug from this category we have is ampicillin. It is active against all the organisms which are sensitive to penicillin G. Also, these are active against many gram-negative bacilli, example Haemophilus influenzae, E. coli, Proteus, Salmonella, Shigella and the Helicobacter pylori. Its pharmacokinetic is, its oral absorption is incomplete but adequate. It is partly excreted in bile and reabsorbed. Here the hepatobiliary circulation is occurred. However, primary channel of excretion is kidney. Its plasma half-life is about 1 hour. Its dose is 0.5 to 2 gram given orally or intramuscularly or intravenously depending upon the severity of infection in the intervals of 6 hours. In children, 50 to 100 milligram per kg per day dose is given. Its uses are, it is used to treat the urinary tract infections, respiratory tract infections, meningitis, gonorrhea, typhoid fever, bacillary dysentery, cholecystitis, subacute bacterial endocarditis, H. pylori infections, septicemias and mixed infections, and the ANU. Its adverse effects are the diarrhea and the rashes, especially in the immunosuppressive patients. The second drug we have is vancomycin. It is an ester product of ampicillin. It have less adverse effects and its dose is 400 to 800 milligram given twice a day. The third drug we have is amoxicillin. It differs from ampicillin in its oral absorption is better. Incidence of diarrhea is lower in case of amoxicillin and it is preferred over ampicillin for bronchitis, urinary infections, SEB and gonorrhea. Its dose is 0.25 to 1 gram given thrice a day either orally or intramuscularly, or slow IV injections are also available. In children, 25 to 75 milligram per kg per day dose is given. Now the second category is carboxypenicillins. In this, the first drug is carbenicillin. The special feature of this penicillin congener is their activity against the Pseudomonas aeruginosa and the indole positive protease, which are not inhibited either by the penicillin G or by the aminopenicillins. Its pharmacokinetic is, it is inactive orally and rapidly excreted in urine. Its plasma half-life is 1 hour. Its dose, it is used as sodium salt in a dose of 1 to 2 gram intramuscularly or 1 to 5 gram intravenously, given in the intervals of 4 to 6 hours. Its indications are serious infections caused by Pseudomonas or protease, example burns, urinary tract infection and the septicemia. Carbenicillin indanyl is an orally active ester of carbenicillin. Carbenicillin is inactive orally and the carbenicillin indanyl is orally active ester, and it is used to treat the urinary tract infections. The second drug is ticarcillin. It is more active than the carbenicillin and also it have less adverse effects. Its combination with clavulinic acid extends efficacy to cover the beta-lactamase producing strains also. Here the clavulinic acid is an beta-lactamase inhibitor. Its dose is 3 gram given intramuscularly or intravenously in the intervals of 6 hours. Now the third category we have uridopenicillins. In this the first drug is piperacillin. It is about 8 times more active than the carbenicillin. It is used to treat the infections caused by Klebsiella, Enterobacteriaceae and some bacteroids. Its elimination half-life is 1 hour. Its dose is 100 to 150 mg per kg per day in 3 divided doses. Maximum 16 gram per day dose can be given either intramuscularly or intravenously. The intravenous route is preferred when more than 2 gram is to be injected. Here we have ended our presentation. Now we will take a short recap. The semisynthetic penicillins, these are produced by chemically combining specific side chains in place of benzyl side chain in the structure of penicillin G or by incorporating specific precursors in the mold cultures. They are produced to overcome the shortcomings of penicillin G, which are their poor oral efficacy, susceptibility to penicillinase enzyme, narrow spectrum of activity and the hypersensitivity reactions. The first category is acid resistant alternative to penicillin G, in which we have the drug phenoxymethyl penicillin or the penicillin V. The second category is penicillinase resistant penicillins. In this group, the congeners have side chains that protect the beta-lactam ring from the attack of the penicillinase enzyme. In this category, we have 3 drugs which are methicillin, cloxacillin or dicloxacillin. The third category is extended spectrum penicillins. In this category, we have further 3 more categories depending upon the type of substitution present in their side chain. The first one is aminopenicillins. This group has amino substitution in their side chain. The drugs are ampicillin, vancomycin and the amoxicillin. The second category is carboxypenicillins, in which the drugs are carbenicillin and the ticarcillin. And our third category is uridopenicillins, in which the drugs are piperacillin and the meslocillin. Now we will see the MCQs. The first is, which of the following is not penicillinase resistant? We have seen the category that is penicillinase resistant penicillin. In this the drugs are methicillin, cloxacillin and the dicloxacillin. Hence our answer is option B, penicillin V. Second is following penicillins are acid resistant except in the category of acid resistant alternative to penicillin G, we have the drug penicillin V. Also, cloxacillin and dicloxacillin are also acid resistant. Hence, our answer is option A, that is methicillin. The third is which of the following substitution in the side chain is present in ampicillin. As we have seen, ampicillin is fall in the category of aminopenicillins, and the name suggests, aminopenicillins have the amino substitute in their side chain. Hence, our answer is option C, amino substitute. The fourth is penicillinase enzyme of Staphylococcus acts on. The penicillinase enzyme is an enzyme produced by certain bacteria which destroys the beta-lactam ring of the penicillin G and leads to their functional disability. Hence, our answer is option A, that is beta-lactam ring. Our fifth MCQ is the special feature of carbanicillin is its activity against. We have seen the special feature of this penicillin congener is their activity against the Pseudomonas aeruginosa and the indole positive protease, which are not inhibited either by the penicillin G or by the aminopenicillins. Hence, our answer is option D, that is both A and B. I hope you understand my presentation. Thank you.